So we're going to start 2 minutes earlier this session, so we have a little bit more time for the discussion. Robert, come in. Good. So it's my pleasure to start session number 8, which basically will address something that is growing in the community, which is the use of the CT scan to plan bifurcation PCI. So the first speaker, no introduction required, for Professor Serruys, who's going to talk about the myocardial blood flow distribution from CT and the implications for surgical revascularization. Professor?
Let's see if this laser is working. Yeah, it's working very well. So that's the title, Myocardial Blood Flow Distribution, derived from CCTA, myocardium at risk, and revascularization completeness in the FASTTRACK CABG, but everything I say could be applied to PCI. And you see the co-author of this paper, and it is on behalf of the FASTTRACK CABG investigate that I'm presenting this data. So there is no universal definition of complete revascularization. However, we know that incomplete revascularization of coronary arteries after PCI or CABG has been associated with a poor prognosis. And complete revascularization is frequently self-judged by operator, PCI operator, but also a surgeon. So this is a paper that we published this year. That's coronary bypass surgery guided by computed tomography without cine angiography in a low-risk population. It was a group of 114 patients. And I would like to mention that in my AC 2024 lectures, the title I received from the ESC was Coronary Revascularization 2040. Good luck. And I said conventional coronary angiography prior to CABG will no longer be performed in 2040. And with the sole guidance of CCTA, decision-making in favor of surgery, PCI, or pharma will be made routinely by the heart team. And CCTA, as a game changer, may change the gatekeeper of the mechanical revascularization. Now, what is the FASTTRACK? The FASTTRACK was a first in man. 114 patients referred to CABG by conventional heart team using invasive coronary angiography. Then they underwent a CCTA with FFR-CT. And then the CCTA was transferred to the Academic Coronary Lab in Galway, blind to ICA, of course. We did a lot of measurement discussed at the time of the heart team with the surgeon and the radiologist and the interventional cardiologist, MPR, cross-section, MIP, 3D reconstruction, anatomic and functional syntax score. And then the core lab sent the result back to the site, but to a different heart team, the heart team called CCTA Planning and Operating Heart Team. That's basically the surgeon and the radiologist blind to CCTA. And then the surgeon can request to see a coronary angiography, and then the surgeon is give access to the ICA and unblind. That's the feasibility assessment. Then they do the surgery, and 30 days later, we repeat the CCTA for graft patency assessment, and that's the safety assessment. So this is the kind of information that we discuss every Thursday in the heart team. It was a proof of concept demonstrating that we can operate patients without knowledge of the conventional invasive cine angiography. And in a nutshell, the result is that in these 114 patients, only in one case we unblind the surgeon, and that was the core lab which was requesting that. That was not the surgeon. And the safety assessment was that 93% of the anastomose patency were patent at 30 days. So that's the maximal intensity projection, volume rendering, the FFR-CT, and then we were presenting to the surgeon who loved it, this multi-planar projection, calculating for them the syntax score. Now, one slide from the paper is that there was an excellent concordance of ICA, CCTA, heart team planning and actual treatment. This is what we call a quantitative Venn diagram, and you see that the concordance and agreement in the planning of revascularization between ICA and CCTA heart team was 82.4% with a kappa of 0.54. Now, this is a complex slide. At the bottom, you have the whole literature, so you can read if you want. It's basically the technique of percent left ventricular myocardium flow. We call that LV percent myo, not to be confused to something name of nomenclature of the PET. And what you do in 5 steps is the LV myocardium and coronary tree are extracted with deep learning algorithm. Then the total LV and non-LV flow are computed based on myocardium mass. That's what you see here. Coronary tree center line are classified as LV feeding or not LV feeding based on a diameter-dependent distance threshold, and you see the reference. Point 4, LV and non-LV flow are distributed top-down in the LCA and RCA in proportion to downstream vascular volume at each bifurcation, so you have a kind of fractal flow division with a flow to volume scaling low down to the outlet of each tree. And finally, you have, as you could see here, the percent LV myo at any location in the tree. So if you look at that slide, in the middle, you have basically the classical heart flow presentation. You could see that the right coronary artery has an FFR-CT just before the bifurcation between the PD and the posterolateral of 0.8. The LAD, there is no problem. Just after the takeoff of the diagonal, you have an FFR-CT below 0.5. There is a first obtuse marginal, small, with a FFR-CT of 0.77. You have the circumflex and the obtuse marginal with 0.68. So if you talk this is the center line, also color-coded, same color-coded than the product of art flow. But now we have at the end of the right coronary artery, the myocardium at risk, 8.3% for the posterolateral, the myocardium at risk for the PD, 9.3, combined is 17.7. Then you see 1%, 0.7%, 0.8%, that small side branch on the way to the bifurcation. So all in total, the right coronary artery is an area at risk of 20.6%. Then you take the LAD, and again you see the big red arrow here is the point where the FFR-CT goes below the value of 0.8, the same for the circumflex. And everything which is in red is in percentage myocardium at risk. You notice that the first diagonal is not involved, and you notice that the first obtuse marginal is there for 13%. So before surgery or before PCI, you had a total LV% myo at risk of 87.2%. Now you have the situation post-bypass surgery. As you could see, there is saphenous vein graft on the right, very highly implanted, amazing, but now the FFR-CT is 0.88. You have a beautiful lima on the LAD, and the FFR-CT is 0.91. And you have a saphenous vein graft quite distal on the circumflex, and it's almost normalized 0.81. So many of these territory which was in red are now in green. The only one which is not normalized is the first obtuse marginal, because the surgeon did not graft that vessel. So the residual LV% myo at risk is 13%. This is the result. The pre-CABG total LV% myo at risk was 70.1%, standard deviation 18.8. The post-CABG residual LV myo was 14%, standard deviation 15.3. You can see the difference with patient having at least one total occlusion versus the patient who have no total occlusion in their multivessel disease with or without main stem. So what we have done now is that we have revamped the syntax score. This is the formula. If you have an LAD proximal with 43% myocardium at risk, you multiply it by 6, which is coming from the segmentation of the syntax, and you get a new syntax score for the LAD proximal, 2.58. On the left-hand side here, you have what we call the fixed weighing factor in the syntax segmentation. You remember the LAD, for instance, was 3 proximal, was 3.5. Now the real value average, this is an average, but you have for every patient is 2.5 with a standard deviation of 0.4. This is important because using the machine learning, we will get now these syntax score automatic. You know, I'm fed up with the tedious, cumbersome, unpleasant measurement of these things, yeah? So this is one of the last slides. It's a syntax segment weight factor derived from measurement, from LV% myo, which differs significantly from the traditional fixed weighing factors. You could see on the vertical axis the weighing factor, and on the horizontal axis all the segments. They are quite systematic difference, not dramatic, but existing. And in an AI system, we want to have the individual of the patient. So these rings show the blood flow distribution according to anatomic syntax segmentation. 58.3% for the LAD, 25% for the circumflex, 16% for the right. The blood flow distribution according to the LV% myo in patient without total occlusion, 41.5 for the LAD, 36.8 for the circumflex, 21.7 for the right coronary artery. And then the blood flow distribution according to the LV% myo in patient with TO, and many of them was in the right coronary artery. You could see LAD 50.5, circumflex 40.6, and right 9%. So the next step, I guess you know that individual here must be in the audience. I didn't check, okay? But the next step is to combine peri-procedural measurement, okay? Measurement of the bypass flow at the time of the procedure with the multi-slice CT scan. And we will need the brain of Yannis to make that kind of combination, but he has already published 2 patients, and he called that patient-specific computational simulation of coronary artery bypass graft. So in conclusion, the percentage of ischemic myocardium in pre-procedure can be quantified on CCTA pre-CABG or pre-PCI bifurcation. Should I do that bifurcation? If it is 6% myocardium at risk, should I take the risk to treat that bifurcation? That's the whole issue for today. The CCTA post-CABG, post-PCI allow the quantitative assessment of the residual ischemic myocardium. This is a unique way to provide individual quantification of the revascularization completeness. Therefore, before the procedure, we can identify the best anastomose site, the bifurcation strategy that will maximally minimize the residual ischemia and help the surgeon on PCI operator in identifying the vessel and subtended myocardium at risk to be revascularized. Now, this morning I put 3 slides more, and this 3 slide is friendly warning to the PCI community about what? About what? The fact that there is a new tidal wave. You know, the last time I used that slide is Amsterdam in 2000. I think drug-eluting stent is coming. There was only 33 patients, so I used the same slide. The new tidal wave is the photo counting. In the next 5 years, with the advent of photo counting detection CT, the disappearance, the conventional invasive coronary angiography as diagnostic tool of CAD will be accelerated. And just now, there is already 150 hospitals in the world. And it is said that by the end of the year, it will be 600. So I'm pleased to hear that Frankfurt will have a photo counting. Now, 2 slides. This is amazing. This is a document coming to the core lab through Filippo Cademartiri. That's the conventional CT. You could see the blooming effect of calcium. You could see the unsharp contour of flow attenuation area. This is the high-resolution CT, less blooming effect artifact, but disappearance of low attenuation area. You don't see that anymore. And this is the photo counting scanner. You have a sharp contour of calcium. At 40 kV, you will not have any blooming effect, and the low attenuation area is still visible. Now, more specifically, this is the quality of the document today. I can tell you it's easy to quantify the left main. It is 9.54 millimeters square. You can do that 10 times, you will get the same value, believe me. And then it becomes a piece of cake to quantify the diameter stenosis. Now we are in a bifurcation meeting, so my very last slide will be this. Photo counting CT can visualize stent strut by struts. You could see here, systematically you see the individual struts with minimal blooming effect so that you can reconstruct that like we did 25 years ago with IVUS gated. And then look, in this case, the metallic carina is clearly visible. So that's for the next meeting, go around to have a session especially on that. Yeah.
Professor, that was fantastic. Any question? If you have a question, go ahead. Take the microphone, please. Behind you.
Incredible presentation, Patrick. So, I have a very practical question. When we are looking at the coronary angiography today, we are correcting the measurement we have by 5%. You know, this is a work you did with Kubo a long time ago. With the proton, the diameter that you will have is
so the photo
has to be modified or not?
No, everything will be modified. It's very simple. I mean, Carlos Collet is very aware of that. The fact that, number one, the resolution is 111 micron. That's the official resolution of the Siemens photo counting. Is the first. There will be 600 at the end of the year, but GE is coming, Philips is coming, everybody is coming. Siemens has abandoned the manufacturing of their multi-slice CT scan conventional. They only now photo counting. That tells you something, you know. And the image we got in the core lab is so clear that on the shoulder of the fellow I can say, oh, that's a photo counting. Yes, sir, it's a photo counting. So that's point number one. 111 micron. That's somewhat better than some old IVUS. It's better than coronary angiography, which is 200 micron. So some of the image, I I can show you plenty. I mean, I have a library now, extraordinary. Some of the image look like IVUS. I think it will compete at a certain point with IVUS, or eventually be complementary. We will know where to look specifically, don't need to make a pullback the whole things, just go where you want to go. That's point number one. Point number two, with the blooming effect disappearing, it's very easy to subtract the calcium. That's what the people do. But now you have a high resolution. So if you look at the finite element of the whole system and the finite element of the same vessel done now, you gain. So everything is going to be more precise. FFR-CT will be more precise. So I think that's the way to answer your question. So the 5%, I don't know exactly what it will be, but it will be better.
Yeah, so I presume that now we'll see how to prepare the treatment of a patient with a CT scan only.
Yeah, we have done that. If you remember, at PCR last year in Clinique Pasteur with Bruno Farah, we made the case completely multi-slice CT scan in this institution, but we make the interpretation and in analysis. And in that patient, we discover a circular main stem, completely calcified, 380 degrees, with some calcium going in the circumflex and some calcium going in the LAD. We said to Bruno, live case for PCR, start immediately with lithotripsy. That's what he did. 10 session, 10 activation of the lithotripsy, short because it was the main stem, and then stent, and it was done.
Good. Last question, Habib?
Quick question. Amazing talk, as always, very disruptive. Question for you is, as you've moved this concept to functional syntax, essentially, but for all three vessels, and really leveraging the value that CT brings over angiography, where do you view the next disruption in this area, and this whole idea that you're not just using the angiography or the physiology as a dichotomous, red-green, but augmentation of FFR? So you think the next level would be to look at sort of a more quantitative or continuous improvement in delta FFR rather than red-green?
Yeah, I think, you know, the term which has been coined by Elucid, by Clearly, by Heartflow is AIQCPHA, which is for artificial intelligence, quantitative coronary plaque, and hemodynamic assessment. So it's complete assessment of the coronary artery. The weakness now is, on one hand, you have to recalibrate everything for the photo counting. That's one thing. The second point is that we have to stay away from the categorical. You know, the 80, okay, 80, that's 1994 in the New England. No, it was 75 at that time. And we moved to 80 with the interventional cardiologists because they were not happy about the 75, and there was a plateau there. But I think that has to be recalibrated for the photo counting. And then we have to use the delta. The ICFA, this group, has put that the first important things, the 5 features which is important, is the delta FFR-CT, then the plaque burden, then the total volume, then the low attenuation volume, and then the LV myocardial flow, which will be commercialized early 2025. Yeah? Okay. So the next speaker is Carlos Collet, the classical sentence. He doesn't need introduction, but maybe he needs some introduction still today, yeah? So it's a good friend. We have been working together for 2 years, I think, in Rotterdam, and then he did a wonderful career, first at the University of Brussels and now in Aalst. The title is 3D Plaque Assessment for Bifurcation PCI Planning.
Thank you, Professor. And of course, everything that you're going to see in the next slide has been deeply influenced by my time with Professor in the Netherlands. But we're going to now shift to the cath lab. And we're going to make this very practical. And the reason why we're having this session today is because this has been, you talk with Professor Serruys and he will tell you that he was doing this 15 years ago, and that was true. The thing that is new is that you have this photon counting. Basically, you go to 100 micros resolution, and then you have AI. So this becomes a click in a software, and this is going to show you in the next slides. So basically, I'm going to make just a case presentation to make the point, and this is typical day in the cath lab, 70-year-old male, angina class 2, normal function of the ventricle and the kidneys, and then you step in the lab, and then you get this shot schema. And then you start thinking, okay, long AD lesion, some disease in the distal left main. Start thinking what would you do, because that's my next slide. I'll give you the still picture. This is basically how we work. So now we have to decide. Now you have to take a decision, and to take a decision, basically here, I will put 4 options for you. Give me what you think about this. Keep it simple, as the EBC promotes, it's provisional to the LAD. Well, there is some disease in that ramus, maybe 2 stents is the best approach. Someone will say, well, why not surgery? Distal vessels are good. Eve said no. And then we'll have someone saying, listen, there's no difference really with revascularization. You can treat that patient medically. And then you say, okay, what should I do? You are at the table. Basically, you have to take a decision. Normally, you only have the angiogram, and you start thinking, okay, how long is that plaque? Do I need to modify that plaque before putting the stent? How big is that vessel? Is a side branch. I'm going to lose that side branch. How important is that side branch? Do I have to modify the calcium? With what? IBL? Should I take the rota? And this is happening in every single case, and it's worse in every single complex PCI. So the reason why I'm telling you this is because this is what happens in clinical practice. Everyone takes a different decision, and this leads to treatment variability. If you do that in Spain, if you do that in France, if you do that in Belgium, we'll probably decide something different depending on your expertise, the information that you have. And basically, treatment variability results in this, outcomes variability. Famous slide from Professor Serruys, basically showing the event rate in both the PCI and the surgical arm in the syntax trial. And every ball is a different site. So look at the variability in the outcomes according to the randomization arm. This is unbelievable. And the reason is basically what I showed before. Why is this? Well, basically, we're making decisions without really being informed. We're taking decisions based on the luminogram. We don't know anything about the plaque composition. We don't know anything about the disease burden. We don't know anything about the real presence of ischemia, if this is focal, if this is diffuse, and we have absolutely no clue about the microcirculation status. So this is where the adjunctive technology plays a big role. We are fans of invasive physiology, but maximum 30%. That's the numbers from the Netherlands. And intravascular imaging is the same. The top country in the world, outside the Asian countries, is 20% adoption. So how can CT help? And this is extremely relevant, again, because it's fully automatic. Now, of course, we have started the presentation by showing the clinical and the angiographic picture, which is basically something that we have for every single patient, but we need to turn on the light to look at the plaque, to look at physiology, and we're going to go back to the case and understand how those 2 information basically help solving this case. Let's assess the plaque. And to assess the plaque, we have basically developed a curriculum to train interventional cardiologists. So if you know nothing about CT, this is everything you need to know. There is nothing outside this slide that you should be aware if you are doing PCI and you're looking at a CT scan. Basically, you have 4 names. These are the 4 reconstructions that you need to remember. The 3D MIP is extremely intuitive for us. It will tell you the amount of calcium, the actuals we use for the guiding selection, the NPRs to assess the lesion and the lesion length, and of course, the cross-section is pretty similar to what we do when we look at IVUS or OCT. Now, back to the case. This is the same case. Now, we suddenly realize that the plaque extends to the left main and to the mid of the left main. Very easy to see. Then you see the plaque there. Basically, it's a left main PCI, and you have to land mainly in the proximal part of the left main. Clear. Second answer, beautiful landing zone in the mid LAD. And what is even better, a 48 covered the whole plaque. So basically, you have now understood that a 48 will solve the whole problem in the LAD. And again, when you look at the cross-sections, I'll come back to the calcium analysis, but you don't see any circumferential calcification. That's good news. You can also see the other vessels. And you see, well, there is no so much disease in the circumflex, which is in the middle. There is something at the ostium of the circ, and the ramus is free of disease in the ostium, but there is some disease in the proximal ramus. Now, you don't need to learn how to do that. You don't need to learn how to look at those pictures. And the reason being that those pictures that we call MPR, this is all being now reconstructed in 3D. This is the same case, 3D mesh reconstructed, and now you see that the calcium becomes white, the non-calcified plaques become green, and if you want to look at this case, now this is what you have. And this is going to be in front of you in the cath lab. We're going to show you what we're doing. So basically now, this is the same case. You understand the disease. So basically, you see the plaque in the left main. You see that there is a trifurcation. You know where to wire. The circumflex is 90 degrees. There is some calcium at the level of the ramus. And then look at the augmentation of information that you had just by analyzing the CT scan in this way. And to put something on top of that, this comes in the lab. So this geometry you put in your C-arm. This geometry is synchronized with the machine. Every time you move your C-arm, the geometry will move at the same time. It's extremely powerful to see the lumen on one side and the complete plaque in 3D next to it. It's like the feeling is that you have been blind for your whole life looking at the angiogram, and suddenly you can see the plaque. Now, when we talk about the calcium evaluation, I will not go in depth, but you need to know that 30% of the severe calcium we cannot see with angiograms, and of course, this impedes extent expansion. And again, this correlates linearly with the arc of calcium, as Professor Serruys mentioned. And again, this is data from Christos, which is in the audience, basically showing that in severe calcifications, we have higher mortality compared to absence of calcification in patients undergoing PCI. So this type of calcium detection is extremely relevant. This, again, the same case. Now I'm plotting only the calcium in that case, just to show you that, again, there are no circumferential calcifications. The position of the calcium relative to the side branch, which is something that we're learning, is extremely important for the selection of bifurcation techniques. And again, this also helps in wiring. The field of calcium is, in my view, something that is being revolutionized by CT scans, and I will explain you why. This is all the data you can derive from CT relative to calcium. This is going to go to a complete new level with photon counting, but all the images that I'm going to show you are with the old scanners. I'm going to call it old scanners. Basically, you can look at morphology in the same way you do with intravascular imaging. You can look at the 3D calcium, and there is something that is coming that you can not only understand calcium in terms of how severe it is morphologically, but how hard or compact the calcium is. And we're going to talk about density. And something that I'm not going to talk today, but Professor Okutso is somewhere in the audience. He's been working on predicting wire bias, which is basically a tool that will help us select the calcium modification tool. Calcium arc is very easy. It's even easier than intravascular imaging because you see this white image, which basically is this calcium. It can be circumferential, non circumferential. You can assess the thickness. And of course, it becomes very, very easy because you can also assess the length. Now, this is where CT adds value to the conventional morphological approach. I'm going to go slowly here. On the bottom of the slide, you have an extraction of a three-dimensional calcium, which is the same one that I showed you before, but removing the lumen. In the mid panel, you have all the cross-sections, now looking at the arc, and you will say cross-section A, 180 degrees, cross-section G, F, H, and I, 360 degrees. But on top of that, we have now the Hounsfield's units. The Hounsfield's units reflects the density of the calcium. So how hard is the calcium? So we're not talking anymore about concentric and non-concentric calcification. We're talking about hard and soft calcium. So all are calcium, but some are soft and some are hard. And you can imagine the clinical implication. Of course, you have soft calcium that can be broken very easily. If you have hard calcium, you have to do it differently. And again, all this can be easily co-registered. And imagine that you have these maps before you go in the lab where basically you get a complete three-dimensional plaque of your calcium on top of your angiography. And this is basically happening today. Now, I'll show you a couple of cases that we had to deal with. This is basically a mid-LAD. And what you see here, we call this calcium, when it's above 1.5 K Hounsfield's units, these are very difficult to open. Sometimes this is, we deliver 80 pulses IVL and we didn't open. When you have calcium, we have calcium above 2K. Calcium above 2K is almost impossible to crack. And this is basically what we have been learning in the calcium arena. We're going to have a dedicated talk for myocardial mass. This is a different algorithm. We're using this again. I will show you what we're doing in the trial. But basically, in the same case that we had before, we understand that there's a big, big ramus next to that LAD. And look at the size of the ramus in terms of mass. It's the same size of the LAD. So you're going to revascularize the LAD, you cannot lose that rainbow. So that's important. So, and everything, all this information is given to you before the lab. And of course, I'm going to end up by telling you that you can also, as Professor Serruys mentioned, add physiology. And physiology, Habib, not in the classical less than 0.8, more than 0.8. I think that's the old way of using physiology. Physiology has advanced tremendously. Today we're using physiology completely different. We're using physiology to understand whether, one, is this a case for PCI, yes or no? Because in the meantime, we understood that we cannot treat diffuse functional disease. That's another story. And then to predict the improvement in flow. Now, back to the case. This is a patient with focal coronary artery disease. All the pressure losses are in the ostial LAD. If you want to look this in the pullback, you can understand here very quickly that it's a big pressure gradient across that proximal and ostial LAD. And if you want to calculate the non-invasive PPG, you see that is very high. Now, imagine that with one click for every single case that you're going to do in the lab, and this is not the future, this is the present, you have a complete map of the anatomy of that patient and a complete map of the physiology of that patient, and then you basically execute the case. So it becomes easy now, because all the questions that we had at the beginning, we'll basically can now simulate, well, let me put a 48 from the mid-left main to the mid-LAD, basically will improve the FFR to 82. That looks pretty good. But, well, then you basically go in the lab, give me a guide, 2 wires, put that 48 in the proximal LAD with extension to the left main, and that's it. And this is the way we're executing PCI today, and what appeared to be a very complex, uncertain disease becomes a straightforward PCI. We measure post-PCI FFR in this case, and it was 0.85. So this is everything that you can get from a CT scan today relative to PCI. So basically, you can understand the complexity of the disease. You can select the best guiding for the takeoff of that vessel. You can understand the need of plaque modification specifically for calcium. For bifurcation lesions, understanding the mass at risk changes the procedure many times. You can get the best angulation. This is something that you get in the lab. And of course, you can get the complete physiology in the traditional way, positive or negative, but in this new advanced way of using physiology, which basically predict the outcomes in terms of angina relief. Everything that you have seen before, we're basically finishing the P4 study. This is a randomized clinical trial, including a little bit more than 1,000 patients, randomized to CT-guided PCI, which is basically everything that you have seen in the previous slides, versus IVUS-guided PCI, which we believe is today the standard of care. We have included 720 patients. We think we're going to finish by December of January. So in a couple of years, we'll have the results of this trial. So to conclude, I think that CT has evolved tremendously, and it allows today to characterize coronary artery disease both morphologically and functionally. I think the P4 approach is basically testing two elements. The first element is the planning element, which is extremely important. Going in the cath lab, exactly knowing what to do. And second, the online guidance. Having that plaque reconstruction in front of you all the time really makes a difference. And I truly believe that, I think we are fully aligned, Professor Serruys, that CT will become the standard of care for planning revascularization procedures. Thank you very much.
Fantastic talk. I have one question for you. So I've been wondering for a while why it is that we don't get access to this fantastic detail that you're telling us about. And we mostly get a report that says moderate lesion may be in the mid-LAD. That's all I'm telling you. And what I was thinking is that partly because you actually need the whole data set of the CT scan to get this, and what we all get on our imaging systems is just a small section of that data set. So if I go onto my PACS system and try and recreate what you've done there, I will struggle. Is that because only a certain amount of data is uploaded in most hospital systems and the rest is kept on the radiology server?
Yeah, so the answer is very simple, David. The radiologists, they choose what to put in the PACS in terms of reconstructions. So what you need to have is a discussion with them. I have to say that the first reconstruction that I showed called 3D MIP is perhaps the most important projection for you because, one, you will understand that very quickly. Second, it will tell you how complex is the disease. Based on that picture, you not only know how complex is going to be the PCI, but you will change size of the guiding, even access site. So you will really understand what is the complexity that you're stepping in. But the radiologists, when you tell them, please put the 3D MIP, they say, you want to put what? We don't look at that picture. We don't look at that picture. So
That's true.
we have come into a moment where what we want from the images is not what the radiologist has been trained to look at. That's the reason when you go to our courses of CT guided PCI, you have to look at the images because the radiologists have never put a stent before. You are the one who's putting the stent, so you need to know where is the calcium, how is the calcium. Now, I will tell you right away, you will not need to open the packs. All this information, this DICOM, will be processed 2 to 5 minutes processing time, and you will get all the three-dimensional stuff, which will make your life extremely easier. And that is not the future. That is happening in the trial. And this will be available as soon as the evidence is collected to support this.
Let me do a few comments. First, it's the second time that I heard the story. I heard 3 weeks ago in Milano during the European Association of Cardiovascular Imaging. And I had the same pleasure today than 3 weeks ago. You know, it's like a good movie you want to see a second time, and I got the chance to see a second time. I don't know if you realize, but it's dealing with very complex material in a very educational way. I was looking at the audience. When the audience take the iPhone, is a bad talk. Nobody was using at the iPhone because they were following the talk from the beginning. Okay, that's the compliment, and we stop here. Now, the second point is that when you are in the audience, you must have some feeling of frustration. You know, I don't have these things. And what is complicated in life is that if Carlos, myself, Yoshi start to say, that's system, that software, that algorithm you could find here and there, you will say you have a conflict of interest, you are promoting something. But when you leave the audience, the people come to you and said, where can I find this software? And I think that ABC should have the gut to say, forget the conflict of interest, say where you have the software and who is the person, because we are all entitled to have this information. And it's a question, it's not tomorrow, it's not science fiction, it's not Star Wars, it is the reality today. I mean, it's amazing that what we were doing in the past in 2 hours, you know, these kind of pictures, is done now in minutes, okay? And it's on the cloud. You can interfere with the cloud, but the concept of core lab will disappear because all of us will have access to artificial intelligence, which is not to make us afraid, but it is to facilitate our operational task every day. Yeah? So at the end of the meeting, you consult Carlos and said, give me the address of all this software. That's my advice. Question, Francesco.
So, no, it is just one comment. For sure, I mean, it was fantastic to see this movie. But I want to come back. I think that you let us see our future, and it's good. However, I want to share with you what I think that for all the community is the present. That is the fact that regardless we have or not the software, it is time that before performing PCI, if a patient received a CT scan, even if it is low quality, even if it is without contrast because of a possible lung cancer, the operators come back to see the DICOM file by his own. This is something that should be the statement because as TAVI operator, I learned to use all the fancy devices that allow us interpret. But if the machine doesn't work, I will never implant a TAVI without having a look on the DICOM file. And it takes really a few seconds to have at least, I mean, the main information we cannot miss today. So this is a call for action for each of us. Let's start seeing the images, because at the end, we will be better in selecting the best, let's say, software that will be proposed us according to our knowledge.
Francesco, I think that I'll tell you two things. The workflow that we have for PCI basically takes between 3 and 4 minutes, and we standardize that for the trial, and that's what we're telling the community. It's 4 minutes. Look at this, guiding. Look at this, IVL yes or no. Look at this. So it's like TAVI, you know? This is a workflow that is solved. And the second comment you made is extremely important, and yesterday I did this lecture about young physicians, but even in STEMIs, I tell the fellow, they have a chest CT, open the chest CT, let's look at the calcium, let's see how much calcium it is before we do the primary PCI. So I think I cannot agree more with you.
Okay, there are 4 potential questions. Question short
Yes.
answer.
Go.
My question is, what is the role of intravascular imaging and physiology when you have this technology available? And when you have it, how many times are you using this technology?
Short answer. I think this facilitates the interpretation of intravascular imaging. That is extremely, when you have a 3D plaque, it's very easy to know where you're looking at the cross-sectional plane. So that's one option. But to give you the controversial answer is that for the pre-PCI part, CT solves almost all the questions that you will answer with intravascular imaging, pre-PCI.
Thank you very much. More than frustrating, I think it's motivating to see all this. One question, from the mechanical and morphological point, it's absolutely clear, but what about biological factors like in acute settings, how they would compromise also in the previous talk, the blood, myocardial blood flow and all this analysis?
Yeah, you know, when you speak about biology, I focus on PCI and calcium, but there is a big part of CT for vulnerability, assessing the vulnerability of the plaque, of the activity of the plaques. And I think this is a fascinating topic. We're still learning a lot about that, but what has really changed in that field is that we now have a tool that is screening the patient for us. Because in the past, no one would screen with IVUS or OCT, but now everybody's getting one of these when they have a little bit of chest pain. So I think that field is going to really be enriched by the fact that we can look at the morphology, at the risk, at the plaque level. So that is what I see coming.
In acute settings, can you use the same thing?
In ACS, non-STEMIs, yes.
Do you think the CT scanner should be part of the cath lab because structural is doing it? If we do it now in this setting, people with pulmonary embolism are doing it, and that's a political fight. And do you think our trainees should get this training separately, and what about radiation safety?
Yes to all. So yes, all the interventional cardiologists that are starting or young physicians should get trained on how to read CT. That's point number 1. Point number 2, yes, I think that cardiology should little by little start owning the CT scan because this is just going to evolve. Professor Serruys presented the surgical part, this is the PCI part, but this just continues to evolve, so yes.
Okay, Joanna, and then Borantas, and then that's it.
No, that's okay. I think that you sort of asked my question about IVUS, and you also answered it. So, I mean, what is the percentage of the cases then where you plan with the CT, but you find something different, it goes differently, and then you rely on your IVUS and FFR? I mean, because, you know, you have to also check what is actually your result post-procedure, right? So, and that's, you can...
Yeah, so intravascular imaging, as I said, pre-PCI is pretty much solved with these pictures, but after you place a stent, you will need to have intravascular imaging either to assess the effects of modification or the placement of the stent. So it becomes more kind of a checking tool at the end.
Chris, last question. Yeah.
Very quick, Carlos. Fantastic work. And this is important the technology to be pushed and brought to the lab, especially with the photo counting. From my experience, what I have seen, there was quite a few cases that, for example, fibrotic plaques can be missed by CT because they have the similar Hausdorff units with the contrast. And the other thing is, I've done a CT, I measured the lumen diameter, for example, to size a stent. Then I did a balloon angioplasty. I put an intravascular imaging catheter, give some nitrous, have a different vessel. Have you seen something like that? I mean, I don't believe that does not have a value CT in the cath lab, but sometimes we see different vessels with after dilating a lesion and missing some fibrotic plaques. And the Broca calcification as well. You can see the calcium, but don't know where exactly it is, it's superficial or not. And most of them would be resolved with photo counting, of course.
That's a very important comment, Chris. And you know, a few days ago, I was in a similar meeting, but with radiologists. I'm not talking to radiologists. And the reason that I'm talking to radiologists is because they need to understand how important it is to give nitrates to the patients, because we're doing now sizing. So if they don't do nitrates and you do nitrates, that's going to be different. So they need to understand that they give to give nitrates and that they need to set up the tube in a way that allows to assess the calcium. Because what they have been doing so far is reducing the radiation at the expense of getting this blooming artifact that you cannot read the calcium. Now we're teaching them, listen, forget about the radiation, because what is going to happen is that in the cath lab, we're going to give 5, 6, 7 times more radiation. So it's better for us that you make a diagnostic exam that we can use, that we spend more time in the cath lab. So that they started to understand that to look at calcium and to be, perhaps you can talk with your radiologist, you need to use 120, 140 kVs, otherwise you cannot look to the calcium. So these are small details, but both communities, the interventional community and the radiological community, are understanding that this is, a CT is beyond a diagnostic test, and we're using that for planning, and that's going to be the future.
We have to stop, Joanna, because we give plenty of time for the question. Carlos, you're still in the phase where you will have in the audience in Dutch, ja maar, or in English, but. Chris starts by but. He's a young man, but he has a but. So I think that it will take some time. I mean, it took me 10 years to go from the balloon to the stent, 10 years to go from the stent to the drug-eluting stent, and another 10 years to go back to the balloon. So that's part of the history. You know, don't be worried about that. You will have followers, like in a crusade, more and more, but it will take time. Okay, we go to the next now. David, you want to announce the next speaker? Yeah. So we stay a little bit in the same topic with mass at risk and PCI bifurcation strategy, Frederic Bouisset.
Thank you very much, Professor. So, ladies and gentlemen, dear colleagues, it's my privilege to be part of this session to discuss about mass at risk when we are planning a bifurcation PCI. These are my disclosures. So, getting the mass from CT, how does that work? Well, we have seen this a bit in the two last presentation. We have basically two methods to get mass, specific vessel mass from CT. The first one is the Voronoi method, which is based on anatomy, and the second one, presented by Professor Serruys, is a hard flow method, which is based on the flow. This is practically speaking how we use in the core lab the Voronoi method with the software. We just upload the CT, a normal CT, no photon counting, good CT quality, but normal CT. Automatically, the software has recognized the myocardial, left ventricular myocardial mass. It has recognized the coronaries and the branches. And if you are willing to know the mass of a specific branches, just like in this example, you just drop a point. For example, in this example, we wanted to know the mass of this diagonal, and we know that the mass is actually 13%. The fractional mass of this diagonal is 13% of the mass. So we can also get the mass in volume, in milliliter, and if you wish, you can convert this in grams if you are willing to know the mass in grams. But for bifurcation topic, it's probably more relevant to discuss about fractional mass in percentage. So this has been validated against histology in a clinical validation. And this is the hard flow principle. This has been detailed by Professor Serruys. Basically, it's based on the flow, hard flow model, based on the mass of the ventricles, the total flow that will subtend the myocardium, divide this flow in all branches based on the branches diameter, and then as mass and flow are proportional, we can get the fractional mass for every branches. So why is this relevant? Well, in a recent document published a year ago by the EBC together with Bach, there was an emphasis put on the relevance of the side branch. Basically, actually, it was stated that the relevance of the side branch is important to qualify a bifurcation as such, especially in a study perspective. If we wish to discuss about bifurcation, we should know how important is a side branch. And in this document, it was stated that CT is one of the tools that we can use. And what is a relevant side branch in terms of prognosis? Well, it's a side branch that subtends more than 10% of the myocardial mass. We can get this from CT, as we have discussed and seen in the previous slides. And if we don't have CT, we can also get this with angio based on the length of the side branch. This is from a previous work from the group of Bonkuku. And those branches with a myocardial mass more than 10% are relevant in terms of prognosis. That doesn't mean that you would be happy to lose a branch that is subtending less than 10% of the myocardial mass, but in a PCI perspective, maybe in a bifurcation, that would be probably worth to discuss a two-stent technique, for example, if you have a side branch that has a mass that is more than 10%. And we admit that in a left main bifurcation, whichever is a side branch, it's always more than 10% of the myocardial mass. And this 10% is coming from this paper that we all know, that we have seen many times from Ashamovich years ago, saying that 10% is a cutoff to say that this is a prognosis, that has a prognosis relevance. So it's probably good to have in mind some repairs. This is a work from our group, the group of Carlos Collet. A colleague took 1,000 CT and analyzed almost 10,000 vessels. And we saw that in average, the mass of LAD is 43%, 29% for the left circumflex, and 27% for the RCA. But probably even more relevant is this analysis of the side branches. You see that PDA, PLB, and first marginal usually make the cut of 10%. First diagonal is usually around 8%. And what was very impressive to us is the mass of the first septal, which very often is almost 10% and very often even more, actually. So it's probably good to have in mind. Of course, what is very important in this mass distribution is the dominance. These are two extreme examples with a huge RCA and a small left circumflex. The circumflex in this case is 11% of the mass. And this is the opposite example in which we have a left dominance with a circumflex which is 54% of the mass. So if you were to do left main PCI for those cases, maybe you would not consider them the same way, probably. This is to show that indeed the dominance has a huge impact, especially on left circumflex and RCA mass. That's obvious, of course. So how to use this in practice? Well, I will show you a couple of examples. This is a case with two, I would say, big diagonal. I mean, if you ask me, I would say that both are big, actually, and both are diseased, by the way. But I don't know, if you were to treat those diagonal, I don't know which one would you choose, but we were very surprised when we did the analysis of mass to see that basically the second one is basically 2 times the mass of the first one. So in this case, we chose to treat preferentially the second one for prognosis, of course. This is another example in which we were about to treat this lesion in proximal to middle AD, crossing over 2 big diagonals. And again, the question would be, which one will I protect? Of course, you are experts in bifurcation. Maybe you are not afraid to use 3 wires, but in daily practice, sometimes we prefer to use only 1 wire to protect the diagonal, and we have to make a choice. That's also something that you can do based on mass. And in this case, it was obvious to see, you see that the diagonal 2 is actually 10%, while the diagonal 3 is 5%. So we choose to protect the diagonal 2 and go for a provisional approach with the second diagonal protected. So finally, an example of how to integrate this in a bifurcation PCI planification. The previous speaker has detailed everything that you can get from CT. This is an example of a bifurcation between left circumflex and first marginal. We saw from the mass analysis that both branches are actually relatively important. And this is the outflow model. We have a deep ischemia in this lateral territory. And from the outflow planification, we saw that one stent approach from left circumflex towards the distal left circumflex would be okay, but somehow disappointing in terms of flow improvement in the first marginal. 086 is not that good for a non-LAD lesion for post-PCI FFR. So what if we stand towards the marginal? Then we would be disappointing by the flow in the distal circumflex. So in this case, we conclude that a 2-stent approach would be probably worth, and that was done in the lab by the operators. But most importantly, this was planned upfront. Upfront, we knew that we would go for a 2-stent approach, a 2-stent technique. Again, you are all experts in bifurcation. You are not afraid by doing a culotte, but it's not the case in every lab. If I'm not comfortable in 2-stent technique, if I knew upfront, maybe I can do with a colleague who is an expert in bifurcation or more comfortable to do complex cases. So in conclusion, the myocardial mass is, especially in the context of bifurcation PCI, is a very relevant information, especially in trial perspective to qualify bifurcation as such. you saw that with a dedicated tool, it's just a couple of clicks, literally a couple of clicks, very easy to do with specific tools, and combined, as explained brilliantly by Dr. Collet just before, with all the information we can get with the CT, we do think that this would enhance our planification and hopefully will improve patient outcome. Thank you very much.
Thank you, Frederic. That was a very complimentary talk, I think, for everybody. One question that I have immediately, we are a little bit in a prognostic context.
Yeah.
We don't want to lose 25%, maybe we can lose 6%. But what about in the context of symptoms?
Yeah, definitely.
Can 6% of 8% be as annoying than 15% in terms of angina?
Yeah, that's a good point. Actually, in this document that I showed before, it was clearly stated that the cutoff of 10% is made for prognosis. And of course, we may have a patient having symptoms for a lower mass, 8%, 9%. So why not doing PCI for if it's technically accessible and if not controlled by medication for a smaller mass? But this is not prognosis approach.
So I think we have maybe to revisit the data from Courage, because that 10% date now, what, 12, 14 years ago. I saw this week that ischemia has been completely analyzed by Jim Min. I didn't have the time to read the paper, but I'm curious to see if there is something in terms of myocardial mass and prognosis. Any question? Now, Carlos.
Yeah, concerning so I think this approach really tailors the PCI strategy. I want to just answer your question and then make a comment. Your question on symptoms. We're analyzing the data from Rasha Lamé from the recent trial in the Orbita family where she inflated the balloon and see if the patient has symptoms or not. So we'll have the answer on how much mass triggers symptoms. Probably not definitive, but some guidance in terms of that. Now, this data of Abramovich, I don't know if I pronounced that name correctly, but it's basically too old and coming from PET. So I think this 10%, you use it. I use 5. You know, Frederic, what do you? I use 5. You know, I don't want to lose anything that is bigger than 5. If it's less than 5, I don't mind. But I have to tell you that I've been impressed by losing some septals that have 15, 17% of mass. These septals produce a lot of symptoms in the lab. You get a huge troponin. All those go to the Kaplan-Meier curve. So I think by having an understanding on how important are the mass of the side branches involved, I think you can. I'm protecting septals now in my PCI, so this is how my practice has evolved based on this.
Yeah. So one of the things you've not taken into account is large acute RV marginal branch that you might jail in right coronary stenting, or diagonal that you've left that can cause symptoms, not only symptoms, but sudden cardiac death, or large acute RV marginal branch being jailed, causing RV infarction. So where does that fit into the picture?
Yeah, that's true. That's a limitation of this analysis. We are only taking into account left ventricular mass, not right ventricular mass. Yes.
No. Yeah, excellent presentation, and Carlos, your work has been great showing us again. So David asked us before, so it's all on the DICOM files. It's just on the coaxial slices. But you have your own workstation. We use it for the CT, it was already mentioned before, and we have to prep our heart team better because, you know, these are big questions. So it should be a side branch with a large mass. It's a side branch where you see the ostium is diseased, so I have a big chance to lose it during the procedure. And if I'm going to go for a two-stent strategy, I go back to my question, should I go back to the heart team and say, if I do a two-stent strategy, a large bifurcation, there's multiple disease, the outcomes are poorer, we know that also from Patrick, then maybe you better go back to your heart team and say surgery is maybe a better option. So yes, mass is important, the ostium is important, is it going to be two-stent, going to lose it, etc. So great work, and we should all prep our heart teams better. I think that's your message.
Patrick, just one question. I just want to say that you know, I think the message about the journey that you gave us, right? Always go back to history and say, you know, where have we come from with angioplasty stents? I said there's no question that CT is the next frontier for sure, And I think that some of the software, Carlos, that you're working on and others are going to be critical for that. I do think that today CT is going through the same process that angiography went through 20, 30 years ago, where image quality does matter. If you've got a 64 slice, 128, et cetera, the acquisition parameters, the amount of contrast, the artifacts, all those things, garbage in and garbage out. So I think the software and AI will allow us to correct some of that. But the exciting point, as you said, with the photon CT is really the evolution and the standardization of practice patterns with CT, so we can leverage it. So I do think that it's going to take us, a number of years to kind of bring this into the clinical practice, but absolutely disruptive and very exciting.
So the point that you are making is very important. I mean, photo counting is eliminating two layers. Okay, the photon is immediately directly transferred in an electrical signal, if I want to say that in one sentence. So it's a quantum leap in the technology. It's not another CT. No, it's another concept. And that's what the people, I think maybe next year we need a short introduction for Mr. Everybody, and I'm part of it, about what is the photo counting. Yeah.
The questions there remains a bit the same. So you're jumping in quality and resolution in calcium detection. You're not jumping in speed. So you say 100 micron. The heart sometimes is more moving than 100 microns in this acquisition window of 250 microns or 200 microns. So, and the body mass of our patients go up, go up, go up, and the radiologists go down in kV. So I think that we have quite some problems left. Quantum leap, yes, problems remain.
But if I can make just a comment, of course, photon counting will solve this quality problem, but already with standard scanner, if you go to your radiologist, explain what was mentioned before. This is, when you see calcium, please increase the kV, please use nitrates. If you go to your radiologist, show the type of images that they can get, that you want to get. Already today, with their current machine, they can probably do better. But we need to push, that's also our role. We need to go to ask them, this is the standard now, please improve your quality. I'm in France, photon counting in my hospital is not for tomorrow, I know. But already, with what we have, we can improve our quality.
Okay. Yeah, one question from my side. How good is the assessment of the myocardial mass in patients who have got a proximal lesion in the main vessel, and you assess the branches? For example, a proximal lesion in the LAD, significant lesion, and you have lesions in two diagonals. How do you assess? How good is the assessment?
I think the next talk will talk about that. So I think it's a good question. Now, I just want to say that at the ESC, I had the privilege to present hierarchical phase contrast CT. That's the next generation. It's if we have the time, it's a video of 2 minutes. It's amazing because the voxel is now, listen carefully, 2.26 micron. Voxel of 2.26 micron. I will not tell you how they get there, but the pictures is amazing. It looks like an OCT, better than an OCT. Yeah? So that's, if we have one moment, we'll put the video just to have the electrical shock, and then I will tell you how it is done, because it's a little bit misleading. Thank you, Frederic, that was very good. I don't think that anybody is a volunteer to introduce the next speaker, but that's my partner in crime, if I can say so, for 15 years. So Yoshinobu Onuma, Professor Onuma, will talk about comparison of FFR-CT, Murray-based angiography, and I see that Dr. Tu is still in the audience. That's a good news. And QFR, impact of serial bifurcation. That's probably the answer to your question.
Yeah. Thank you for the introduction. So this analysis is part of the FASTTRACK trial, which already have been shown by the Professor Serruys. So as you know, that there is a fractional flow reserve derived from the coronary computed tomography, FFR-CT, such as heart flow, quantitative flow ratio, and also the Murray law-based quantitative flow ratio, Sanven just presented in the previous sessions. And those are the image-based non-pressure wire-derived FFR tools for the diagnosing and potentially planning of the treatment of the obstructive coronary artery disease. So those technologies have been developed and also tested in clinical trials, and as you could see that in the new guidelines, the QFR is listed as a 1B recommendation for the physiological assessment. And Murray law-based QFR, myoQFR, is a novel computational method using based on a single view, so you don't need two views anymore, and also taking into account the side branch diameters by the Murray's law to compute the fractal flow division. So this just analysis was to investigate the correlation and agreement with between the FFR-CT and QFR and the myoQFR at sequential side branch point in patient enrolled in the FASTTRACK CABG trial. The one kind of disclaimer is this patient has the 3-vessel disease and or the left main disease, so it's a very complex coronary artery disease. So the diagnostic accuracy of the QFR, FFR is not really a problem for this population because anyway patients need the revascularization. So we try to really use these technologies to plan the procedures, and actually those patients were treated with the CABG, but you could also use this technology for the planning of the PCI. So all patients underwent the CCTA and angiography, and FFR-CT, QFR, and myoQFR were calculated using the heart flow, Medis Angio 2.1 software, and Pulse Angio Plus version 3.0 software, respectively. And FFR values were calculated at a sequential side branch point with all 3 softwares, and we measured the FFR at the point of polygon of conference, the end of the polygon of the conference polygon of the conference in the distal main vessel. So it's just distal to the bifurcation. So the sorry, this should be this way. Yeah. So these are the physiological principle of 3 technologies. Heart flow is based on the CT, and reconstruction is very complete in the sense that all the side branches, coronary arteries, are reconstructed based on the CT images, which is very easy to present in a 3-dimensional reconstruction. Medis QFR is based on the 2 angiographic projections, and you need to have 25 apart 2 projections, and it's based on the Landschool equation, and it's as some veins show that reference diameter is tapering model, so it's only the one line of the reference diameter. And for the pulse myoQFR, the Murray's law is implemented, so you can see that the reference diameter is somewhat changed over the at the point of the bifurcation, so it's accurately calculate the reference diameter. So the software of the heart flow recognize the side branches because all side branches are reconstructed in 3 dimensions. myoQFR also recognize the side branches in this analysis. Medis does not really see or calculate the side branches in its analysis. So these are the population. We had 114 patients, 342 vessels, but we exclude the CTO because there's no need for the CTO to do the QFR, and the software doesn't give the values. So we have 266 vessels, and because of the technical problem of the angiography or the FFR-CT, we excluded some vessels. So in the end, we have 199 vessels analyzable for the FFR-CT, QFR, and the myoQFR. So this is the images of the one case we did for the analysis. You see that MIP and volume rendering. This is a MPR, curved MPR, and this is the FFR-CT images. So angiography, we need to calculate Medis. We have 2 projections, and for the myoQFR, we could derive this measurement from the 1 projection with the minimum overlap. So what we have done is that we just co-localized all these projections. So for the CT and angiography, we have exactly same projections, and we could also derive the pressure curve from the FFR-CT, also from the Medis and Pulse. We also look into this each bifurcation. So in FFR-CT, the major side branches were reconstructed. So each side branch point just distal to the polygon of conference in the main branch. We measure the QFR or the FFR-CT. And for example, for this Medis, you could really locate the exactly same side branch on the angiography. And for the each side branch point, we look into the QFR value along this main vessel. Same has been done for the pulse μQFR. So you could see that already there's some difference from the first branch, which is 0.78 in the CCTA heart flow, which is 0.98 for the Medis. For the pulse, it's more close to the heart flow analysis, 0.88. And along this analysis, there is some trend toward the little bit higher value with the QFR Medis. So these are the just entire analysis. So we have a 984 measurement points. So it's a little bit difficult to comprehend or grasp the message, but basically if you compare by means, the QFR is the 0.0 by 0.026 higher than the FFR-CT. The limit of the agreement is 0.244 and minus 0.295. If you compare the μQFR and FFR-CT, the systematic difference in mean is very minimum, just 0.004, and relatively similar limit of the agreement was observed, 0.245 and minus 0.252. So if you divide that each level of the side branch, the first side branch from the proximal, so including left main or the major bifurcation in the right coronary artery, you could see that the value of the FFR-CT is 0.94, QFR was 0.97, and μQFR was 0.94. So there was a significant difference between the FFR-CT and QFR. QFR is higher than the FFR-CT and also than compared to the μQFR. There was no difference between the FFR-CT and the μQFR. Same were observed in the second level of the side branches. So you can see that on average, the FFR-CT has a value of 0.87, QFR 0.90, and μQFR 0.88. Third side branch is also same. The QFR has highest value compared to the other two modality of the image-based FFR. Fourth side branch, the number becomes relatively small. In that level, still the QFR has a higher value compared to the FFR-CT, but there's no difference between the QFR and the μQFR. And fifth side branch, apparently not so many patients have the 5 side branches, so the number becomes a bit lower. In that level, there's no difference between these 3 measurement, FFR-CT, QFR, and μQFR. This is the same data, but dividing into each level of the bifurcation, like left main, diagonal, obtuse marginal, etc. You can see that left main has already shown that the QFR has the highest value, 0.97, compared to the 0.93 of the FFR-CT and 0.94 of the μQFR. So there's no difference in the diagonal D1 level. However, if you go for the obtuse marginal, there was a significant difference, again, highest with QFR compared to the other 2 measurements. Obtuse marginal 2, there's no difference, but for the right coronary artery, the major bifurcation between this PL and PD, then you can see again some difference. The QFR has a value of 0.82, which is significantly higher compared to the FFR-CT 0.76 and the μQFR 0.77. So in general, the QFR has the highest value. Of course, we have seen that improvement of software with the Medis as well. So the analysis, what I have shown, was done by Medis 2.1, but now we have a Medis 3.0. This is how the Medis 3.0 works, and it has a more automatic calculation of QFR, and also the algorithm was somewhat improved in terms of the reference vessel diameter calculation. So work is ongoing to use this Medis 3.0 to update this analysis. But so far, what we have found is that if you compare the Medis and Pulse and the FFR-CT, the value of the QFR is in majority of the bifurcation a little bit higher than the other two modalities of the imaging. MyoQFR were not significantly different from the FFR-CT in this side branch analysis. So these results suggest that the implementation of the fractal law or the bifurcation law is very important for the image-based FFR measurement in bifurcation. And I think for the next step, we want to extend this analysis using the latest version of Medis software. And I think we need a further research and analysis to confirm this result in a larger population and also look into the some validation in the phantom. Thank you for attention.
Yoshi, thank you very much. That was a very comprehensive presentation. And I have to say that I was a bit shocked when you showed the correlation plots, because removing these points in the 0.5 line that we know is because the FFR-CT cannot go beyond that, but even removing those points, you see that the scatter is significant. And although you have a mean difference that appears to be low, the limits of agreements are huge. You have almost 50 points within the limits of agreement, basically meaning that 68% of the data will have a difference of 0.15 or something. So it's quite large. In the context of the limitation of the study, which is that you don't have the gold standard.
Yes,
That's a big, I think, the biggest limitation. But how do you then, and I make these questions to you too, because you have been pioneering this new kind of insights into this technology that perhaps is not so accurate as it was shown at the beginning. So how is your thinking evolving on the real accuracy of all these technologies after this study?
Yeah, thank you for your comment, and I agree that we are also a little bit shocked to see this result. But the one thing is that for this population is very severely diseased, so syntax score is 44. So it's not about the diagnostic accuracy. Anyway, if you go to the end of the analysis, in the end of the vessel, the FFR-CT is more or less than 0.8. So it's not about diagnostic accuracy of the vessel level or the patient level, but I think that has an implication when you use this technology during the procedure, because in the procedure you have to select the which bifurcation should be treated and how. So I think it's more a little bit subtle, and it's not about the diagnostic accuracy, but for the planning phase, I think it's important to take into account this difference, and I think further validation is probably needed for this population. And I didn't show that, but also the PPGI and the other parameters we have tested in this population, and we have seen that the PPGI is completely different from the three technologies. So I think we need really more data to validate these technologies.
Yeah. Yoshi, can I ask one thing? So PPGI will be actually overestimated by the Medis QFR from what you're showing, right? Because if it doesn't take into account the side branches, it will be already lower and will show you more diffuseness of the disease. Is that correct or not?
Yeah, so yeah, I have actually the one, maybe can I come back on my slides? I have that in a backup slide. And
so, yeah,
that was a comparison of the PPGI index in the QFR and myoQFR and FFR-CT. It's yeah, so the FFR PPGI index value is higher with the QFR, so you're right. I think it's not picking up probably the diffuseness of the disease, and FFR-CT and the myoQFR has a lower value, which means that it's more diffuse. But yeah, also the three values are very different, so I think we need a further validation if you really try to use it for the planning of the PCI, which is different from the diagnostic accuracy, I assume. So.
You know, it's a very interesting story, because if you think about it, what is determining a gradient? A gradient is determined by the flow and the anatomy. So basically, it's a long discussion with Nico Pels in '91, okay, when he wanted to introduce the pressure measurement of the gradient. I said, I'm sure you have to do it because the anatomy is poor and the velocity is poor. So for almost 2 decades, the golden standard, the validation is versus the pressure. But I can tell you, when the anatomy got a resolution of 20 micron, 10 micron, 2.5 micron, as I was mentioning, the finite element of that plus the flow will be superior to the pressure. The pressure is just 1 point. In that lectures about how do we see revascularization 2040, I was illustrating my case that I think in 2040 we are no longer recording the pressure. For which reason is that more and more, take the MRI, you have all these vectors, and you can have the velocity of all these vectors that's far more superior to a pressure at 1 point. It will take time, it will take 1 or 2 decades, I will not be there, but for sure, I think pressure will disappear. And the imaging, getting a high resolution, is the determinant of the pressure gradient. That's the paradox. It's indirect product. It's a surrogate.
So to answer, that's the music, Bernard. If you are very applauding, it's because I have to move. I just want to make one last comment, is that for the question you made, Joanna, I think it's important we look at this, and Professor Serruys and myself have been looking at all this angio-FFR systems and the simulation of FFR, specifically addressing the pattern of disease, which is, as you know, that's the next step in physiology. And we have, last week, we published the first validation, invasive versus angio-FFR, and basically, you need the pressure wire. You need the pressure, that's the short answer.
So we start 1 year ago with this iconoclastic paper and JAK intervention, and I think that the IMR will be the next victim in the process. But okay, so let's go on. And the next paper is Nicolaj Brejnholt Stortrup. I hope that I pronounce that more or less correctly. It's case-based presentation integrating anatomy and physiology. So we will have a reconciliation at the end. I think it's a video.
Dear Chairman, thank you for the invitation to present at the European Bifurcation Club 2024 meeting. The title of my presentation is Case-Based Presentations Integrating Anatomy and Physiology, CT-Guided DK Crush and Provisional Percutaneous Coronary Intervention, the P4 approach. This case was performed at Aarhus University Hospital, Denmark, in collaboration with Core Alst, Dr. Carlos Collet, Dr. Frederic Bouisset, and Dr. Hirofumi Ohashi. I have no disclosures. This case is a 75-year-old gentleman with stable angina, CCS class 2. He had a previous history of bicuspid aortic valve disease and hypertension, and treated with ACE inhibitors and beta blockers. He had a normal ejection fraction and preserved renal function. The CT was acquired on a Siemens Force scanner using 90 kVs and 70 mils of contrast. He was moderately symptomatic and scored 69 on SAQ-7. This rather busy slide illustrates the structure of CT-guided intervention broken down into 3 distinct phases: a planning phase, a strategizing phase, and a potential outcome phase. Initially, we obtain information about coronary anatomy, calcium load, and global calcium distribution, and this helps us to stratify case complexity. In the axial view, we can appreciate coronary ostium takeoff and plan for optimal catheter selection. Lesion characteristics are seen in curved and straight MPR and cross-sectional views to help understand plaque morphology, lesion length, and requirements for vessel preparation and stent length. The myocardial mass at risk can be seen and help to identify important side branches that need protection. And optimal angulation may be explored to achieve best available projections. Finally, physiological properties can be integrated through computational models of fluid dynamics, identifying severeness in stenosis and predicting post-PCR FFR. Using this workflow, we could see a moderately calcified LAD with steep angulations in both the left main and LAD diagonal bifurcation. Disease involved both the LAD and the diagonal without any proper landing zones in the proximal LAD. The myocardial mass analysis showed that the diagonal subtended 12.2% of the left ventricular mass, deeming it important for protection. The CT showed a calcified lesions and areas of concentric calcification. Likewise, the diagonal And the bifurcation core and areas just adjacent to this area showed high lesion complexity involving moderate calcium and plaque, and furthermore, the presence of calcium in the main vessel on the contralateral side of the diagonal, raising concerns for the ability to achieve a systemic stent expansion and possible carina shift. Both the circumflex and the RCA showed no signs of significant disease. A computational fluid dynamic models was created by HotFlow and showed a significant pressure loss across the LAD and first diagonal branch. By using these in silico prediction models, two stent strategies were developed. One proposing a provisional approach across both diagonal and circ, and a two-stent strategy involving the LAD first diagonal bifurcation and a provisional approach across the left main. And this is the angiogram showing the LAD in orthogonal views, confirming angulated anatomy and severe osteal disease, involving in particular the LAD D1 bifurcation. Pressure wire physiology testing confirmed significant disease in the LAD at 0.75. Confirmatory iris aligned with the CT demonstrating circumferential calcium in the LAD just exceeding arc of 180 degrees and fibrocalcific disease in the proximal LAD. So based on this information, there are a variety of different treatment strategies involving the possibility of medical therapy, different PCI approaches from balloon angioplasty, provisional stenting of main vessel to complex stenting involving two-stent strategy in the LAD diagonal bifurcation. We chose a two-stent strategy out of a safety approach with a concern for the diagonal bifurcation, risk of severe side branch dissection during side branch pre-dilatation, and risk of difficult rewiring after a provisional attempt. So I chose a systematic two-stent approach by DK crush technique for the LAD D1 bifurcation, addressing the severe disease in the bifurcation and proximal diagonal branch. Lesion preparation was done using a semi-compliant 2.5 balloon in the diagonal and a 3.0 scoring balloon in the LAD. A science 2.5 times 28 was implanted in the diagonal. LAD was stented using two stents with overlap distal to the LAD D1 bifurcation, and the distal LAD was stented with a science 3.0 times 28 millimeter stent. The proximal LAD into the left main was stented using a science 3.5 stent platform. After subsequent second post-dilatation pot and second kiss, and a pot kiss pot in the left main bifurcation, the angio showed a good result. Post-PCI physiology confirmed a satisfying result with 0.86 in the distal LAD and 0.90 in the diagonal. This was further substantiated by confirmatory iris showing good stent expansion in the LAD and good stent expansion in the diagonal, proximal LAD and left main. So in conclusion, this case demonstrates a novel approach incorporating CT-derived anatomical and functional procedural planning and guidance in a case of complex coronary artery disease. And this comprehensive non-invasive planning approach is currently being tested in the precise procedural and PCI plan study, the P4 trial. Thank you very much for your attention.
Okay, I have no idea of the timing. I think we are a little bit behind, no, for sure. So if there's no burning question, I think we can make the conclusion. And the conclusion is, from my point of view, multi-slide CT scan is going to stay in ABC. It's here to stay. Okay? Okay, thank you very much.